Good morning. Yeah, I try to speak to you in English. Okay. I would like to introduce myself. My name is Franco Migliozzi. I live in Rome and also in Padua, north of Italy. First of all, I would like to thank everybody who has organized the AOPA Congress and for giving me this opportunity to present my methods on the apperceptive, proprioceptive of the food. I founded in 1989 with Mara Dott, the Italian School of Osteopathy in north of Italy. And I had taught the osteopathy since then. But I have continued to practice my manipulative treatment with the emphasis to the rehabilitation of the posture. During my many years of practice, I noticed that the most experienced of therapists could rehabilitate the spine, readjust shoulder, knees, but most of them in difficulty when facing a flat foot. Even more fascinating is the efferent sensorial aspect on which our apperceptive concept is based. Neuroreceptor information starting from the feet, balancing and deambulation data, which can be integrated with the other receptor information of the spine. This double aspect is inseparable, both in postural diagnosis and as well as in applying therapeutic rehabilitation. Maybe it was commonly thought that the insoles were only used not to worsen the collapsing of arches and were indicated as a lift therapy when treating a short leg syndrome. Any other possibility of functional recovery of the juvenile flat foot seemed to be excluded, even in absence of serious neuromuscular skeletal dysfunctions. Therefore, I felt the necessity to have an instrument that could be effectively used as a synergic support in my postural work, able to give a dynamic input to the foot and not a static support of the arches. A child's foot represents a postural buffer for its excellence. In fact, is a like diaphragm that mediates postural changes which normally accompanies growth. More than once I wondered which were the elements to the anatomic integrity of the foot and which was the therapeutical effect on the commonly prescribed insole which obligated the foot to have apparently a normal shape. Traditionally speaking, the elements of the integrity of the foot are the ligaments and the capsules, which are passive support, and muscles, which are active elements, as they contract. Traditionally, the orthosis plantar prescribed to a child isn't respectful sensorial elements which the foot represents. we have noted that the use of elastic dense granular material can wake the foot as he worked on small pebbles. We advance the hypothesis to re-educate the juvenile idiopathic flat foot. It will be necessary to, firstly, a varus biomechanical guide during the calcaneus resting. Secondly, in intermediate resting, a proprioceptive stimulus of the helic-podhelic winding. Thirdly, a redirection and strengthening of the propulsive act borne by the forefoot. I noticed that there is a third component which is not considered and which determines the action of the two previous ones. That is the sensitiveness of the foot or proprioceptive foot, which in particular lacks in so-called idiopathic juvenile flat foot. So, together with a restricted group of colleagues, starting in the 19th, we tried to find a method which could rehabilitate the foot and, generally speaking, the complete posture. What we did was to invent an insole to be put inside a normal shoes. The insole contained a number of pockets, some on which were filled with granular latex. Notwithstanding the fact that they were not positioned to support arches, we did notice that a postural rebalancement took place in our patients. Therefore, we began to think that maybe the pockets worked on stimulating the proprioceptive foot whilst correct his posture. Furthermore, we noted that since the osteoplant and receptive insoles that mainly give a proprioceptive reinforcement and not a passive support to the foot structure, therefore they are not effective in anatomical problems as severe structural collapsing of the arch, in which the foot need an anatomic bed and not a stimulated one. In always uneven ground, as it is in nature, every muscle group is stimulated and utilized in a different way, and the receptors remain efficient. On flat ground, the organism seeks to and tries to save energy, deactivating or render less reactive certain devices considered to be unnecessary. On artificial ground, always homogeneous, the same group of muscles are stimulated. Therefore, if a muscle is weak for whatever reason, it will be assisted by the synergist or excluded from postural variation. Hence, the weak muscles will become even weaker, and the strong ones even stronger. It is known that the foot is supported by the heel, the first metatarsal, and the fifth metatarsal. The more these values are far from the standard percentage, 50% anterior and 50% posterior, or major or minor weight anteromedial, anterolateral, the more we can find the changes in the arches of the foot. In the anteceptive method of the helic-podalic winding, we conferred an input bilateral weight, see, in the middle foot, and weight input on the helic-podalic winding with neurotonic action. In the forefoot, a rod is placed behind the first metatarsal head or at the transversal arch. It was noticed that apart from improvement of the propulsive action of the foot, in which the body center of gravity is moved towards the anterior, it also had an effect on the knees, which tend to be in valgus. So far, nothing is being done, concretely speaking, to modify the patterns which I have reported. In fact, the common foot orthosis is made by fixing the arches, sometimes increasing the bearing surface, which is often made from 3D casts, so to simply redistribute the weight on the extension of the bearing surface. In doing so, according to us, the only effect obtained is that combining a passive support to the capsule ligament apparatus, but inhibit the muscular recovery, which could be spontaneous, and also desensibilize the sensorial termination of the foot. These are the criteria used, which we are showing you roughly. We think that this ampliceptive podalic method applied to the juvenile idiopathic flat foot in absence of important neuromuscular skeletal pathologies or dysmorphism represent a valid contribution to the functional rehabilitation, simply because the foot is trained in a single phase of the ambulation and forcing modulating the lucky three-dimensional movements, which are defined by us winding and unwinding of the podalic propeller. This study was conducted by an indirect method, but with utmost scientific rigor, being impossible, use a simple group of subjects with a normal foot to purposely disequilibrate and to rehabilitate. We have observed that the proprioceptive rehabilitation sensorial of the juvenile idiopathic flat foot, apart from significantly reducing the dysparamorphism, at the same time it also rebalances the disharmony of the postural tonic system. One cannot deny the narrow correlation between the correction of the receptorial podalic defects and an improvement of the foot and spine's postural behavior, both in static and dynamic. Contrarily, I must recognize that in the subjects taken into consideration, sometimes the dysfunction of the feet were secondary to the descendant progression. Of course, I have ascertained from applying manipulative osteopathic treatment properly to verify the essence of this research. My experimentation was concluded after 12 months. The results were very encouraging. I continue to follow my intuition. Even so, I knew that I was completely swimming upstream against the everyday belief, because I believe that to demolish the absolutely conviction, and a strongly underlying conviction, really I should say a dogmatic one, that the flat foot has to treat it by lifting the collapsing medial arch and sustaining the astragalus. In fact, in 2002, I presented for the first time during a symposium in Rome the apperceptive podalic concept, advancing the hypothesis that the rehabilitation of the juvenile idiopathic flat foot was to use a winding input which foresees a lateral wedge. There was a lot of people smiling, and I nearly didn't terminate my work because of this. Luckily, I continued to polish up my apperceptive method, and now I'm here, and pragmatically I invite you to choose a patient suffering from the juvenile flat foot and carry out a simple modification in an insole of his or her everyday shoes, placing a medial concavallus wedge in the hind foot, an inverse point at the medial foot having a neurotonic winding propeller bridge action, a bar placed behind the first metatarsal head to aid the right direction of the propulsive thrust. In this way, one induced the flat foot to 3 sequential input during the calcaneus resting, complete placement, and lastly, during the propulsive thrust. Certainly, you will, within 6 months, obtain an improvement, not only in foot posture, but also in that of the spine. I'm very pleased to share my new idea with you all, and I hope that it maybe give you some food for thought, not only in your life, but also in your profession, and of course, some benefit for your patient too. Thank you.